ਕਰਦੇ ਸੀ। ਬੱਚਿਆਂ ਦਾ ਹੈ, ਮੈਂ ਕਿਹਾ ਕੀ ਫਰਕ ਪੈਂਦਾ, ਜਿੰਨਾ ਕੁ ਸੁਣਿਆ ਗਿਆ ਠੀਕ ਹੈ। अच्छा, ये आर्मी ने कीता?
आर्मी ने शुरू च आर्मी बुलाई, बाद च बाकी वापस आ गए क्योंकि असमा हो गया सी, कहते ਜਿਹੜੇ नहीं वापस आਣਗੇ ਉਹਨਾਂ ਤੇ ਐਕਸ਼ਨ ਕਰਾਂਗੇ।
ਹਾਂ, ਅਸੀਂ ਤਾਂ ਬੜੇ ਪਿਆਰ ਨਾਲ ਗੱਲ ਕਰ ਰਿਹਾ ਸੀ, ਫਿਰ ਪਹਿਲਾਂ ਤਾਂ ਬੜਾ ਖੁਸ਼ ਹੋ ਕੇ ਦੱਸ ਰਿਹਾ ਸੀ, ਪਿਆਰ ਨਾਲ ਤਾਂ ਖੈਰ ਉਦੋਂ ਵੀ ਗੱਲ ਕਰ ਰਿਹਾ ਸੀ।
खुशी सी पूरा सक्सेसफुल हो जाए।
ਐ ਹੋਣ ਦਿੰਦੀ ਸਰਕਾਰ ਤਾਂ ਫਿਰ ਤਾਂ
ਹੈ ਕਿ ਹਾਂ ਤੁਹਾਡੇ ਨਾਲ ਮੀਟਿੰਗ ਕਰਾਂਗੇ, ਤੁਹਾਡਾ ਕੰਸੀਡਰ ਕਰਾਂਗੇ, ਆ ਕਰਾਂਗੇ। They will not issue the letter of intent till the court hearing March 10th ਦੇ ਬਾਅਦ ਜੋ ਵੀ ਹੋਣਾ ਹੈ।
What is letter of intent?
ਤੁਹਾਨੂੰ ਤਾਂ ਪਤਾ ਹੈ letter of intent ਨਹੀਂ ਜਦੋਂ ਕੋਈ ਹੁੰਦੀ ਹੈ, ਬਿਡ ਹੁੰਦੀ ਹੈ।
ਅੱਛਾ,
ਫਿਰ ਉਹ letter of intent ਉਸ ਕੰਪਨੀ ਨੂੰ ਦੇਣਗੇ ਨਾ ਕਿ ਤੁਸੀਂ ਆ ਜਾਓ, ਟੇਕ ਓਵਰ ਕਰੋ।
Recording in progress.
ഒമ്പത് പത്തല്ലേ, ഒരു മണിക്കൂർ ഇന്നും ക്വസ്റ്റ്യൻ കഴിക്കോ? ഇന്നും ക്വസ്റ്റ്യൻ കഴിക്കോ? സർട്ടിഫിക്കറ്റ് കിട്ടിയില്ലല്ലോ.
കൂടെയുണ്ട്, ഏതായാലും ഒന്ന് ശരിയാവും.
Good morning, all. Thank you for joining us today. Good morning, Arun. I hope your connection is okay.
Good morning.
All good.
Good morning, Arun. Good. So, good morning to all. Shall we start our program today by a minute of silent prayer?
Amen.
Good morning once more, and a warm welcome from the Department of Pediatric and Preventive Dentistry of Pushpagiri College of Dental Sciences in Tiruvalla, Kerala. I am Elizabeth Joseph, Professor and Head of the Department, and it is my pleasure today to welcome each one of you to our program and also to introduce you to our speaker of today, Dr. Arun Mamachan Savior, who is an eminent speaker as well as a scholar and is familiar to many of you. Dr. Arun is currently working as reader in the Amrita School of Dentistry, Cochin, and is also pursuing his doctoral degree under the guidance of Dr. Balagopal Verma, who is a principal of Amrita Dental School, and also Dr. Nigel King, associated with the Universities of Hong Kong and Western Australia. Dr. Arun mastered in pediatric dentistry from A.B. Shettick Dental College of Niti University under the guidance of Dr. Kavita Rai, bagging the Best Outgoing PG Student Award by overall performance in the year 2010. And ever since, he has been winning several more such awards, a few of them being the Bright Smiles, Bright Future Award from Glasgow University, Glasgow, Scotland in 2015, the Special Recognition Award in 2016 from the IDEA Regional Branch, the Young Periodontist Award from the Indian Society of Periodontic and Preventive Dentistry in 2017, the Young Researcher Award in 2018 from the International Award of Excellence of London, Academician of the Year at the Indian Dental Conference in 2018, the Specialist Dentist of the Year of 2018 from Famden Dental Oscars, and besides, he has been consistently receiving the Best Presentation Award of all ISPPD conferences 2011. A very remarkable profile, Dr. Arun. And his areas of special interest include perinatal counseling and medically compromising conditions of children. Arun has also successfully cleared the Part 1 exam for the membership of the Faculty of Dental Surgery to the Royal College of Surgeons of Edinburgh and is currently preparing for the Part 2 paper. On the family front, Arun lives close to Cochin. He's married to Dr. Steffi and they're blessed with 2 young children, Brian and Carol. Personally also, I have listened to Dr. Arun on a few occasions and he has never failed to impress with his intensity and depth of his presentations. Today, he is with us for a short period of time to discuss about the challenges of pediatric dentistry and how to work around it. Welcome, Dr. Arun. Thank you very much. And wishing each of you a good day. And Dr. Arun, the stage is now yours.
Thank you so much. I would appreciate if I'm not a co-host because I get these messages people are entering. If I'm just moved out of the co-host, it would be great.
Sure, Arun, I'm doing it.
Our next program for today is a message, sorry, Dr. Arun, a message for the principal, Dr. George B. Burgess, is principal of Pushpagiri College of Dental Sciences.
Good
Welcome,
morning,
sir.
Good morning. Good morning. I think I am an intruder. It was a nice start from. Can you hear me?
Yes, sir.
Dr. Elizabeth, can you hear me?
Yes, sir. We can hear
It
you.
was a nice start from Dr. Anud. I should not have intervened.
No, sorry,
okay.
it was a mistake from my part. So please.
No, it's so good morning. And Dr. Elizabeth has already welcomed you. But it's my pleasure to be here with you on this August morning. Respected Chief Resource Person, Dr. Arun Mamachan, our Director, Dr. A.B. Padakandala, Head of the Department of Periodontics, Dr. Elizabeth, senior faculty members, interns, and my dear postgraduate students. Dr. Elizabeth has chosen the right person for this online program. We should have gone for an offline program, but because of the pandemic, we have restricted it. Actually, we were not expecting this much of crowd. So much of overwhelming response has been there because we expected nearly 100. Now I was told that it has crossed 165. So that's a very good response. And it's no doubt the topic has been very important and very relevant. That is the dental treatment of pediatric patients as challenge. And more important that I should add that it is the what has attracted the viewers or the participants is the young, dynamic, and the renowned periodontist Dr. Arun. That's one of the main reasons, I think. And the topic chosen is also very relevant because can you hear me, Dr. Elizabeth?
Yes, sir. We can hear you very well.
Because you are looking at this side and that side, I thought something is happening. Okay.
No, we can hear you very well.
Okay, very good. And very often, what comes to my mind at this juncture is that very often the general practitioners try to avoid the pediatric patients because they feel that they are not competent, and somehow they will refer to a periodontist even for the simple treatment. It's because I think because they are not that much confident in managing the challenge they are going to face when they come across the treatment of a pediatric child. And I could learn from the brochure that Dr. Arun is talking about some of the most important. I think when we talk about the pediatric patient management, the triad comes there: the pediatric patient, the parent, and the doctor and the clinical dental setting. So he's going to talk about all these three aspects which comes to play while managing the pediatric patient, like the how to manage the child behavior and the influence of the parenting style and the dentist role. So these are the topics I was told he's going to talk about. And no doubt this is going to help all the participants that will learn a lot from his experience, from this experienced and very competent periodontist. And very often we know it is the fear and the anxiety that is preventing and the care of or why the child is not cooperating. And there are a lot of definitions for fear and anxiety. And the fear is something that is unknown that is going to happen, or there is a definite threat that is coming, while anxiety is something unknown and it's not a indefinite threat, or we don't know what is going to happen. So these two happens, there will be a physiological response, like the increase in heart rate and the muscle tension, the shortness of breath, and ultimately it will result in the flight or the fight response, which we face in the pediatric patients. They will try to kick at us or bite or try to get out from the chair and run away. So that flight is, I'm sure Dr. Arun is going to detail how we can avoid this flight and fight response from the children, and how to make this cooperative, by the child patient cooperative with this vast experience. And I wish this program all success. Thank you. Thank you very much.
Thank you so much, sir. Thank you. I'll definitely do my best. Thank you, sir.
Thank you, sir.
So can I have my the screen shared now?
Yes, sir.
Yes, Dr. Arun, please go ahead.
A request to all participants to kindly keep your mics muted during the program. If you have any queries, please share them on the chat box. And in case of, we'll have a discussion at the end of the session, and feedback forms shall be shared at the end of the session. Thank you.
I'm not able to share the screen. Please give me permission. Yeah. A very good morning, one and all. I warmly welcome each one of you this morning to my presentation. Have a good day ahead. I begin this presentation with a very beautiful quote. Education begins the moment we see children as innately wise and capable beings. Only then can we play along in their world. My dear friends, this is a very common scene that is seen in our daily practice, especially in clinics where they treat children. What we should understand is every child is unique and different. Every child might behave a different way in each of their visits, and thus it is important to understand what exactly is this child going through in their family and in their day-to-day life. It gives us an insight of what exactly the child is going through by their behavior in the dental clinic. I'm very sure many of you would have had experiences where one or many children would have, run away or taken the opportunity to escape from treatment, maybe before you have initiated the treatment or probably in between the treatment. It is indeed a very embarrassing situation. And this is nothing because of the innate fear these children have towards dentistry. My dear friends, to get the trust and confidence of each and every child who visit you, it is indeed essential that each one of us have the dedication, the patience, and perseverance to handle these children with care. Only then the trust and the bond increases and we can have a lifelong relationship with such children and their families. I would also go with the saying, although the operative dentistry may be perfect, the appointment is a failure if the child departs in tears. Ladies and gentlemen, myself presenting to you dental treatment for the pediatric patient, a challenge. It is very well known that every child, as they progress from infancy to adulthood, go through a lot of changes in their behavior. And this could be attributed to the differences in their physical, psychological, social, emotional, and behavioral development. There is a rapid change that is seen from stage to stage. And this difference that happens from the stages eventually showcases the child in your dental clinic. How the child behaves could be because of how the development has taken place at that particular age. So, understanding the child's needs, his emotional development, his social development for that particular age at that particular time is very essential. The temperament, the inhibition is found to be much higher at a lower age. And it is seen that this becomes slowly controlled as the child moves from childhood to adolescence. And however, when the child grows to an adult, a young adult, his social interaction with the people around him have increased. And this makes it possible that the child understands the situation of how to behave, probably in a dental clinic, in school, in whatever place he is put in. And that makes him a perfect individual. So from childhood or early infancy, the behavioral changes is directly related to the kind of exposure the child is being brought up at. And I should always stress that this is, happening between it's a balance between the theories of nature versus nurture. Nature is nothing but the genetic makeup of the individual. How the child is brought up at home depends on the genetic makeup of their parents or the genetics within him. So it makes a big difference. Every child is different because his genes are coming directly from his parents. It's running in the family, and that's the kind of nature the child is going to put forth. But however, nurture is how the child is being influenced from home, from the society, from school, or whatever. What are those influences that bring up the individual probably in a social background that even gives a balance in his behavior? So always it's a play between nature versus nurture, and that is what balances an individual. As we all know, adult dentistry is a linear relationship between a patient and a dentist. However, pediatric dentistry is a triangular relationship between the child, the family, and the dentist. It is represented as a periodontic triangle, and all the three are placed at either corners of an equilateral triangle with communication happening at either ends. The triangle had a little bit of modification with the norms of the society, but however, the triangle still remained the same with the child at the apex. What I focus through this presentation, all these three entities play a vital role when you try to educate others regarding how you can modify child behavior. Every entity in this triangle, you should understand well in depth. Only then the pedodontic triangle can be made equilateral, means equal amount of communication happening at either ends, and our treatment can be carried out well efficiently. What I should focus and this presentation are going to be discussed in three phases: the child, the first phase, parent, the second phase, and the dentist and his entire team in the third phase. So to begin with, the child and his representation in the apex of the triangle, we should understand what is the psychology of the child from the time of birth as he grows older. And for this psychology, there are a numerous number of theories, but what I would focus around two main theories: the psychosocial theory and cognitive theory of development. Only then you have an idea of what exactly the child is going through. For this, you should also know what are all the different kinds of behavior seen in children. There are, again, a lot of classifications in behavior. Behavior is classified, in a broad scale as cooperative, tense cooperative, and lacking cooperation. But however, Frankel has given a beautiful classification which we could use in our case histories. It is the definitely negative, negative, positive, and the definitely positive behavior. What I would try to emphasize here, what makes a child different from each and every others? And that's all related to the innate psychology of the child, how the child, the nurture, how the child is nurtured at home. That gives a lot of impact in such situations. So to begin with the psychosocial theory, I would try to focus on the first three stages of this. All these three stages happen at different ages: 0 to 1, 1 to 3, 3 to 5, and so on. And it is said that the psychology or the development of the behavioral attitudes of a child begins right from infancy. So as you see, each of these stages have a conflict in the psychological, there's a psychological crisis that is happening in each of these stages. Trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, and so on. And it is said that these three stages would mark how a child would behave in the future. Trust versus mistrust in the first stages. If all the child's needs are fulfilled at the early stages of life, he develops a trust to the person who takes care of him. And this develops into the innate quality of trust in the individual. If all his needs are fulfilled from 0 to 1 years of age, definitely the trust is going to even develop in the future to a dentist. Trust develops not only to the dentist, but to people around him. He would trust people that they are going to work for him. They are doing things for his good. So I would always say, trust versus mistrust, if not settled in the early infancy, it can lead to an innate quality of mistrust, and such children are going to definitely misbehave in the dental center. From this itself, you know that the first stage in their life, they have been going through a psychological conflict. And that's what made this individual to lack trust in you. The next stage, the autonomy versus shame and doubt. The stage when a child gains independence to do things on his own. Please allow him to do so. Don't go to the water, don't go in the rain, sit at home, don't play, keep away from others. A lot of things are pressurized on the child at this age. It is said, if the child is not given the right independence to do things at this age, he's going to have the quality of shame and doubt. He is going to be doubtful whether he is going to sit in front of you properly. He is going to be scared whether he will perform well in front of you. He will try to shy away from you. So all these qualities begin to develop at the age of 1 to 3. Give him the independence to ask you questions. Give him the independence to explore things around you. And if you give him this independence, he gains the confidence to come closer to you and explore things on the subsequent appointments. The initiative versus guilt is the stage from the preschooler from 3 to 5 years of age. Allow the child to ask questions. Allow the child to express himself in the clinic. Give him an opportunity to talk to you. If you stop him from all of these, he's going to develop a feeling of guilt. And this is going to be expressive in all the visits that follow. So it is said, 3 to 5 years, give him the ability to become a leader, to ask questions, so that the same is reflected in his behavior as he grows bigger. So I only focus on these 3 stages of the psychosocial theory given by Erik Erikson. If all these 3 go in balance, it is said that normally all the other stages in life also go in a positive balance. When I go to the next stage, the Piaget's theory, which was nothing but the cognitive theory, it has 4 stages. The sensory motor stage, the pre-operational, formal, and the concrete operation stage. Now, unlike the previous theory, that is the psychosocial theory, which I just discussed, it is said that the society plays a role to improvise the behavior of a child. But here, unlike the previous theory, here the child actively goes and explores the society, the surroundings, and try to imbibe more knowledge. Allow him to do so. Allow him, set him free to understand, explore things on his own. And that's what brings about a good, positive individual. The first stage is the sensory motor stage, where he knows that his senses can be used to touch and feel objects. Allow him to do so. Allow him to touch, feel, and smell the object. And the pre-operational stage, which is an early, it's the early stages of schooling. He again wants to explore things on his own, and he tries to relate it to things that he has already learned before, and he tries to think that this may be this because it has similar features. Allow him to do so. The next stage, the stage of formal operations, which is coming still more later, around 6 to 12 years of age, the child starts to begin to think, the kind of abstract thinking begins to form here. He knows to solve logical problems here. So probably you talk to him in that particular way, he tends to accept you more better. And the last is the stage of concrete operation, where he knows the ideas, the facts of life. Talk to him in a more mature way, and he is going to accept you much more better. So understanding the cognition, to understand the cognition, you should know what exactly happens at each of these 4 stages of life. If you use them appropriately for that particular age, he is going to accept you better. You cannot talk to a 6 to 7 year old child like how you had spoken to a child when he was 1 or 2 or 3 years old. He's not going to accept you because he feels that you do not consider him mature enough to make a decision. So cognitive theory, where it gave much importance to the cognitive principles or the cognitive psychology, if you do not have an insight to this, it's going to make things very difficult in our practice. And a very few examples of the kind of behavior that is seen in each of these stages in Piaget's theory are enumerated, as explained in the next following slides. This is just an example of the concept of conservation. As I told you in the first stage, the child is holding a glass of water and he knows that he's holding an object, and that's the sensory motor. He's touching, he's feeling the glass, and he understands that the glass, if you hold it, shake it and all that, the water will move. So he's trying to explore things that way. The next stage is the pre-operational stage where he knows that what is contained in it is called water. His cognition has raised. He knows how to relate it. He knows to relate what is water, what is juice, and what are its consistencies. So that's what is happening in the pre-operation. The next stage, that is the stage of concrete operations, definitely the child over here knows that the water, even if it is a slender glass or a fat glass, if the same amount of water is poured, he knows that, that can be made, it can be, considered as equal. While the next person, he knows if from far itself, if two glasses are placed, one is tall and short and it's, almost looking like almost equal, he will definitely say, yes, it's either half empty or probably half full. He knows the facts of life. And why I put this slide is because if you recognize the child's ability to think at this particular stage and talk to him, it makes a huge, humongous difference in accepting you as his dentist and in the future. The other some trait qualities that are seen here in the early ages. Now here this from 0 to 2 years of age, the object permanence. This can be also practiced in our clinic. Suppose a child, a very small child is brought in probably of 1.5 years, sitting right, in front of you, and he's quite scared and all that. Probably the one who is there, the accompanying person, along with the mother or parent, whoever has come, probably you can encourage them to do a peekaboo. A peekaboo is they feel that object permanence is nothing but the object continues to remain even when they are not present. This is something like a trait which is seen at this age. Try to do a peekaboo, 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 and the child sees you and he feels so happy and elated at that time. That's the best time where you can examine his mouth. Why can't he use this quality? Why can't you tell the parent to use object permanence for distraction? Definitely it can give a positive, response. The next is mental representation. Probably the child is coming to you at this particular stage and you tell him, see, don't touch that. That is going to hurt you. So next time he comes there, he knows that, that is there in his memory that probably that is touched, it's going to harm him. So a kind of mental representation can be done in different ways, and that is best represented at this age. So don't think that when a small child comes, you cannot talk to him, keep him away, he will not understand. A kind of mental representation begins from 1.5 years of age. So you can actually advise him, don't touch that, keep the light away, don't touch on the light. Probably you will get, a kind of vibration, you will get pain or hurt or something like that. The child is going to remember you. Next time he might just observe the light and keep away from it because that's there in his mind. Last time you had told him, so it's somewhat there in the mind. So this is the kind of mental representation that can be used at this age. The next stage, that is even more elder, up to 6 years or 7 years, something called as, these are some few traits which are seen here, which again, you should keep in mind. About 3 years, egocentrism. You can see the picture there. The child is holding a giraffe and the other one is holding an elephant. And they both are arguing which one is taller. One is saying the elephant is taller, the other one is saying the giraffe is taller. And both just won't accept the other one's fact. The other one says he's just fat, he's not tall. The other one says, no, he's slim and he's tall, and they are just arguing. What you should understand here is, these children of this age, if you come and you try to advise them something like this. See, the decay in your mouth is because of the chocolates is caused because of the germs that have accumulated in your mouth because of the number of chocolates you eat. You give him a statement like this. And then immediately he gives you a reply back saying, no, 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 it's not because of that. It's because my mother told that I brush only once a day. And if I brush 2 times, it will all be okay. You again tell him, no, you try to argue with him at this stage. No, it's because of the germs, it's because of the chocolate, and so on. It's just not going to go into in such kind of children. Just accept it. You can always advise the parent the right way, but at this time, your aim is to gain the acceptance of the child. Than arguing and making a conflict between you and the child. A child who has given you a reply like that, stop it there. Don't try to argue with him because he is going through the phase of egocentrism. This is my advice for all dentists who try to argue and try to establish that you are senior and you are the one who is correct always. Just leave it. There is no point because this stage will pass over. So just educate the parent that this is the reason why the decay has happened and take the necessary precautions at home. The next that can also motivate children to come and sit well is a kind of role play. Here, children would like to enact themselves as a doctor, wear a gloves, do the same procedure probably on their own parent or probably on a teddy bear or something like that, give him a mouth mirror or something like that and allow him to do a kind of role play. This also encourages a lot of children. So if you have a bunny sitting next to your dental chair, allow him to use the same or probably a different mouth mirror and try to examine the mouth of the bunny which has funny teeth in them. So this is naturally going to give him the feeling that it is totally harmless, and that's the same thing that is going to be practiced on you. So this is the quality of the trait of animism. The next commonest thing, which is a lot of literature has said, that children get attracted to a lot of symbols. And these symbols, especially if they are more of smileys, the yellow color, yellow is the favorite color according to articles. And I'm coming to that part later. So if it is a lot of smileys which are there around, children just feel that this is a very happy place. So if you have a room where you actually treat children and you have a lot of these kind of emoticons which have a lot of smiley faces, definitely it's going to increase the positivity in the child. The child is going to behave well in the next time he's visiting. And always children get more attracted to kind of symbols which are placed around. Don't go this way, that way, X-ray, keep away. You have all these kind of symbols around. Children get more attracted and they try to learn things more. And they probably will come and educate yourself. You probably tell the parents, see, you're not supposed to this way. They say no entry, radiation room. Mama, you have a baby in your stomach. You please keep away. This is an X-ray room or something like that. If you have all these pictorial representations in your clinic, it gives a good positive impact because child feels that everything is under his control. So allow him to do so. Still more in an elderly age, there is something called as imaginary audience and personal favorite content. Children at this age, it's a teenage where children begin to feel that they are always being watched. So even obviously you start getting a feeling like that, children tend to become more expressive in front of you. Allow them to talk. You please allow them talking to the dentist, talking to the parent alone, talk to them too. Because this is the age when he has a difficulty in facing people. So I would say imaginary audience, if one child comes up with the saying that I feel very awkward, I cannot express myself, I have lack of confidence because one tooth is inside, people are looking at me, please attend to it. Please give him some good advice, how best you could help him. He's going to come back to you. Personal favorite is also another kind of quality where he feels he is unique. He is unique, he is much more better than anyone else. So he would always tend to look better. Allow him to speak. Than the parent alone giving their inputs, please give some time to him. Because he is in a teenage, he always has this ability to jump from clinic to clinic. Try to gain his attention by giving more importance to him. Because you should understand that these are the two main traits that are seen at this particular stage. Imaginary audience and personal. Allow and give adequate importance to children at this age. What is also very essential is, apart from all these theories, you should also have an in-depth knowledge of the mental processes that are happening at each stages of life. And Goran Koch is a good book which has given a table like this, where they have given a step ladder fashion, where they explain what are the kind of emotions that are happening in child, in various stages, and what as a dentist you should do at each of these stages. Like, for example, in the age of 3 years, his treatment maturity is very less. Maybe he can stand still. He has kind of good memory because he has mental representation. He would appreciate if you talk to him more and give him more importance. Allow him to keep talking, the child of 3 years. And these children are going to behave quite well with you. They are going to accommodate quite well with you. So you have to create a feeling of security in these children and allow them to do role play. So like this, each of these stages, try and understand what is the mental makeup of the child, what is the cognition of the child, and thus you can apply it in the way you communicate with the child. And definitely, children, if you understand the mental process, the cognition, the psychosocial development of the child, and that for that particular age, it is going to be very easy to communicate with such. We come again back to the periodontic triad, and what comes next is nothing but the parent or the caregiver. Parents definitely play a vital role in the child's life, and this forms the second phase of my. As a parent, you have the ability to take part in various or multiple roles in a child's life. But don't you think that you also, these are all the positive ends which are shown in the picture, but there are also other situations where you as a parent could inflict certain kind of emotions in children. And definitely this is also playing on the theory between nature and nurture. How the particular parent was brought up, what are the innate genes that are there from his parents. All this translates from generation to generation. And thus, it's always a play between nature and nurture of the parent, nature and nurture of the child. So if you have an understanding of what exactly the parent is, definitely, again, treatment can be made easier. And that's what I'm going to explain in the presentation. Are you all aware that we are born with just two fears? And the fears are nothing but the fear of falling and the fear of loud noises. This is what happens at the time, when the child is born. These are the two most commonest fears that are seen. What happens? Who are the people who are, manifesting the other kinds of fears in a child, which comes or sets in the child in the future? Like, for example, the most commonest thing, the fear of strangers, very commonly seen in infants and toddlers. So what you should do? So you should always accept. You should not make fun of a child's fear. You should rather accept the child's fear, because definitely if you make fun of them, it's going to increase their anxiety level and lower their self-esteem. You should always reassure the child that fear is normal. And you may also say that when you were a child yourself, you also had a lot of fears. So definitely that kind of bonding should be there between the parent and the child, so that he is more expressive and you can understand what exactly is the kind of fear he's going through. Ask questions. What is that scares you here? Try and have an in-depth knowledge of the kind of fear. Allow him to pinpoint to that particular question that is, causing that kind of fear. And that's the only way you can draw away the fear from the child's mind. Similarly is the case of the fear of dental treatment. They say that the fear in dental needs is revolving around these 5 kinds of fears. The fear of the unknown, fear of pain, fear of lack of trust, fear of losing control, and the fear of intrusion. And again, it varies from the same age, boy or girl, and it's all playing around, as I told you again and again, nature versus nurture, how he is brought up and the genetic makeup of the age. Fear of unknown He doesn't know exactly what is causing fear. He cannot explain. There is nothing to pinpoint to, but he is just fearful. And probably such kind of fear is related to the innate fear. It could have been imbibed by genetics in the child. Probably one of the parents is really fearful of something, and that's what directly translated to the child. Fear of pain. He feels that dentistry is something which would give him pain because probably he heard it from somewhere. So that's the kind of fear of pain. Fear of lack of trust. When does trust develop? Trust, as I told you, develops in the early stages of infancy. His needs are not satisfied at that age. So this lack of trust has developed there. Because there is this underlying lack of trust right from childhood, that's definitely going to, be reflected in a dental setup as well. He's not going to trust you because he's very fearful. He's going to keep away from you because innate quality of lack of trust is there in you. Fear of loss of control. Again, this is showing to the next stage, autonomy versus shame and doubt. He doesn't know that how he's going to behave. He feels that when he sits on the dental chair, he wants to behave like a good child, but he is fearful that he is going to burst out crying. He feels he's going to lose his control, and at the end, the dentist, the nurse, and whoever is sitting around are going to laugh at him. He fears he's going to lose his control. And the fear of intrusion, which is there in majority of people. Nobody likes anybody, intruding into your body, into your own personal space. Similar is the case of an oral cavity. Child is fearful if anybody touches him, if anybody goes into his personal space. And that's called the fear of intrusion. All balance between nature and nurture. All children do not behave the same. Some might be really bold. Some might have, overcome all the crises in psychosocial theory, and they would have, become good, positive individuals, while the other half may be people where some conflict has happened at some stage, and from there everything becomes a mess. How does this fear or anxiety set into the child? It's essentially from the conditioning pathway. Conditioning pathway is nothing but the child personally had an experience, from, his earlier dentist who inflicted some kind of pain. So he relates any dentist who is wearing that same color coat is going to give him some kind of pain. And that's nothing but the conditioning pathway. Informative pathway can come from audiovisual media, can come from, pictorial representations or anything, or, from, people who have shared probably through WhatsApp or anything like that, in images of people, undergoing dental treatment and, suffering a lot of pain. So this kind of information can come from any source. Vicarious pathway is what he hears, what he observes directly from, he's seeing the other child in the other chair getting treated that way, and that child is, crying quite loud. So that's the kind of vicarious pathway which has come from his direct observation from something that is happening around him. A verbal threat pathway is nothing but, again, his own personal friends are telling him that they had undergone a difficult time. Probably their sibling had undergone a very difficult time, and they are coming and telling you. So you naturally get scared as a child. You are scared that any dentist is only meant to inflict pain, or it could be plainly from the parental pathway, which is nothing but probably one of the parents is really fearful of the dentist, and he might have taunted the child maybe at the early stages of his life, saying that, see, if you do not brush your tooth, you will have to go to that dentist. And I had a very bad time with that dentist because he inflicted a lot of pain. So you better brush your teeth. Enough. That's enough. You gave the comment, and that's what set in. So the child knows that the parent whom he trusts the most has said that they had undergone pain, and that's going to set into the child. And that's the parental power. So the fear and anxiety can just come in, can set in from people around. And as I told you, in the early stages, it's just two fears, and all the others are primarily from people who take care of the child, who are associated with the child, maybe at school, maybe in a school bus, maybe in the office, or maybe in his playground, or wherever it is. All these people can set in different kinds of fears. In dentistry, they say that it is based on this vicious cycle that's happening. It could happen because of personal factors, external factors, and dental factors. The personal factors are some children by age, they are fearful, maybe very young child. Either they might have general fears and anxiety, or either their temperament or inhibition is quite high. And some people have neurological issues, and that also can be a factor to avoid or keep away or set in a kind of fear in these children. The external factors are definitely the parental dental fear and anxiety, the social situation of the family, ethnic background, how the child is being reared at home, whether it's a joint family, whether he's given less attention or what. There are so many factors that can also give him a kind of fear and anxiety in dentistry. And dental factors are nothing but purely pain. Child feels dentistry is pain. That's like a fact for him because he's been hearing from many people, or probably anybody around who is wearing a white coat are meant only to inflict pain. So all these three factors together, when a child has, it's definitely going to reflect on treatment. He's having a very bad toothache. What he does, he tries to avoid it, avoid going to a dentist because he's having all these kind of fears. So all this is a vicious cycle. So he tries to avoid going. So then the parent says he's not coming to clinic and probably you prescribe a medication. So he knows that you can get away from a dentist by just a medication. And this whole thing happens again because pain repeatedly comes and again because it's not being treated. And eventually the child is going to suffer with a lot of oral health problems. So fear that began with a very small, influence from someone has set in a negative attitude in dentistry. And thus, it is our duty as a dentist to understand where exactly things have gone wrong and try to help these children to perform, behave properly or behave positively in a dental situation. As I told you, when the triangle is equilateral, there is trust and harmony between the child and the dentist. So this is the kind of the triangle which is there, the ideal. However, as I told you, when there is a kind of dental fear or some kind of, a stress could be the child is too small and the child is crying and the dentist eventually has to spend a lot of time, treating the child. It finally ends up in a situation when the dentist gets too worked up. He doesn't know exactly how to manage his child. Probably his temperament is lost and finally he has to pack up. So the triangle then becomes an inverted triangle where now the whole thing is focused on the dentist. The child and the dentist are now in tension. And what happens over here? The dentist loses his temper. He probably, behaves, he probably even misbehaves with the child. And this finally ends up in a conflict between the parent and the dentist. So how can we avoid such situations in the future? So it is very clear that a one-to-one conversation with a parent and a child can help each and every parent and child to understand dentistry and behave well in the future. So how can we again narrow down to a good conversation? So it is always said that you should understand what is the educational level of each of these parents. So this can be attained when you talk to them, when you understand where they have, when you go into the details of the child, you can also say where you have been and what you have been doing, are you working, and finally you have an idea of what exactly is the educational level of the parents. So if you have an idea about it, you exactly know what is the kind of upbringing the child would have at home. You cannot generalize things, but however, you would have a fair idea of what exactly is happening in the background. So when you try to have a conversation, always make sure that you have used very simple native language. And when you're trying to individualize appointments, make sure that you understand what is the medical condition of the child. And when you're trying to talk to them, always get the details of their family background, their existing oral health practices, the child's likes, dislikes, fears, hobbies, etc. Make a note of all of them. And once you have noted all of them, you exactly know how much time you should allot for a patient like this. And thus, you can custom tailor a counseling program for each of these children in their visits. The best way to approach any situation, any situation in a positive way is to be having a pre-appointment behavior modification. And how is it possible? It's usually practiced abroad. And if this kind of system is brought in or set in here, it can make a positive influence in every child who visits you. And the best way of performing this is through audio visual modeling. This is a very easy way. Probably if you have a video, if you have a picture of children who are being treated or going for a particular treatment, suppose it's a pulp therapy, what was the situation before and what is it now? How is the child performing now? If you have it probably in pictures, share it to them a day or two prior, either through a WhatsApp or however they feel convenient. You share it. That is definitely going to give up. So the parent is going to sit with the child and explain exactly this is the situation that you're going to face the next day in the next appointment. And that's going to make things much easier. The child is going to accept you. A pre-appointment mailing, which is also done. Mails usually are not read. Probably the first option would be better. Having a video, having a picture shared with the child, any day he's going to accept it better. And as I told you, photographs. What was it before and how you have managed it. You put 2 or 3 pictures like this. This is going to be the situation for you in the future. The child is going to accept you much more better in the visit he has when he comes to you. So as I told you again, when you are having an appointment schedule, make it according to the classified needs of the patient and take into consideration the physical, the emotional, and the developmental status as discussed over a phone call. You will also have a pre-assessment of their behavior, the parents' behavior. When you talk to them, you will know what exactly the child actually wants or what exactly the parent wants for the child. You will have an assessment of what kind of behavior it is. However, the best behavior assessment of a parent can be done only when he comes to you for the visit. But however, make your appointment schedule based on the ideology that you have once you have spoken to this parent. There are again classifications of explaining how a parent behaves in a dental setup and how you should modify yourself. So I have put the most simplest classification here, which is a modification of our Frankel's classification of behavior for children. The same way Kupitsky has modified this classification as definitely negative, negative, positive, and definitely positive. The definitely negative parents are those who refuse outright. They refuse your treatment plan. They are very suspicious that you are trying to make money out of him, and they just try to behave very overprotective and say, no, whatever you said, no, I don't accept all of this. These are the definitely negative types of parents. A negative parent, however, they have some kind of reluctance to your complete treatment plan, but however, they are always, in some doubts. They try to establish a rapport between you, and they are always fearful of you. But then, however, they want the treatment, but they are, kind of keeping away because of all their doubts. A positive parent definitely accept all your behavior, but one thing, they will not allow the child to be left with you personally, like alone in a room. They would always want their presence also in the room. They are positive, they accept the behavior, whatever, accept the treatment plan, whatever you have said, but they will still remain. While a definitely positive parent are those who are totally trustful. They believe in you. They treat you as probably even God, because you are the savior for the child. You saved him from his sickness. So whatever you say, exactly that is what I will follow. They allow the patient to be independently with you, and in the room, and they probably will wait in the waiting area. So these are the different kinds of parents that you would actually come across when you are in a clinic. So who are these parents? And how who are these parents allotted for more amount of communication time, and who are those who are less? I would say the definitely negative parents are those who I would give very less of my consultation time. There is no point talking to them and wasting your time, because they are only overprotective of the child, and they feel that whatever they feel is correct and whatever you say is wrong. There is no point wasting and communicating your time. So I keep a very less time for them. A negative parent, when you talk to them, you understand that they want the treatment. So probably if you spend little more time and explain through pictures or videos or whatever you have, definitely it's going to give a positive rapport between you and the parent, and also the child is going to be, accepting you much more better. The positive parent, definitely I would give more time, and the definitely positive, even if I don't give more time, probably if I give my less time, he very well knows that you are there to save him. So probably even if you counsel him or not too much, it doesn't make a difference. So now I have two sets of parents which I would like to focus on: the authoritarian parent and a negligent parent. Now, this is the first equilateral triangle where the mother or the father wants to have a controlled relationship with the child, where he sets limits to everything. And that is what is represented as equal amount of communication between the child, the parent, the child and the dentist, and the parent and the dentist. So it's equal. It's an equilateral triangle, and all these sides are equal amount of communication. However, when it is an authoritarian parent, as I just told you, they feel they are always correct. They are overprotective of the child. They have a lot of questions always. But however, they do not allow you to talk to the child more because they have a lot of questions always. So what happens to this kind of relation? They say that the triangle is now becoming an isosceles triangle where there is an increased communication between the parent and the dentist, while there is less communication between the dentist and the child, or the parent and the child. So the triangle has become more here between the parent and the dentist. The line has become more, communication is more, because the parent is answering on behalf of the child. He interferes with all conversations between you and the child. He's authoritative here, and it kinds of really disturb your kind of treatment. But however, a negligent parent is the one who has very limited amount of questions. So the conversation between the parent and the dentist is not reciprocal at all. They just feel they are very negligent. They don't care whatever you're doing. Now it's your duty to manage the child. You please do whatever he has paid, you manage it. This is the kind of attitude these people have. So what happens to the kind of equilateral triangle? The triangle becomes a right angle triangle where there is increased amount of conversation happening between the child and the dentist, while limited between the parent and the dentist, and the parent and the child. This is the kind of triangle that happens. So based on the assessment that you have made, whether it is a controlled parent, whether it is an authoritarian parent, or whether it is a negligent parent, try to adjust your treatment timing accordingly, and make sure at the end of the day, the child is given more importance, because he is the one who accepts you at the end. If only if he gains your acceptance, he is going to come back to you. He is going to become an adult and again come back to you. He is going to get his children also to you. And this is all a vicious cycle. So at the end of the day, whatever be the parent, whatever be the surroundings around, the focus is primarily on the child. If you give him importance at the end of the day, your practice is safe. You're going to be a good, well-accepted dentist for the child. So there are different types of parents. I am not going to all those details, and I just summarize it in here. The controlled parents are those like the authoritarian parents, the helicopter parents, generation X, concerted cultivation, attachment of general parents, self-motivated parent, etc. All the communication is happening equal. However, in the case of an isosceles or a right angle triangle, as I told you, the amount of time spent either between the parent and the dentist, or the dentist and the child, is going to be exceeded. Make sure you have the right assessment done in your case sheet, so that every time the parent comes with the child, please attend him the same way. It is said that the carry status of these children of permissive parents, the children of permissive parents, is going to be quite high. Why? Because they are negligent parents. There is a study which is published. It said that the children of an authoritarian or an authoritative and a permissive parent, when compared, the carry status of children also had, was found to be more. And so it clearly shows that parents do have a role in causing caries. So always, for your counseling, please try and advise parents that it is seen generally that if you do not care, definitely the caries status is going to be high. A self-motivated parent would definitely also take care of their child with special healthcare needs. And these are the different ways that you can educate them of how well they can perform their duties. If he is in a wheelchair, what is your position? If he is always on the bed, if he is sitting on the floor, or he's sitting on the bean bag or lying on the floor, what are your positions of managing oral care? You can definitely incorporate it in your counseling. COVID-19 has also brought in or set in a lot of psychosocial impact on the behavior of children. Like, there are so many articles that have been published, and at the end of the day, they all say that it's ended up in parental depression. And because of it, it has affected parents' self-efficacy. Parents are unsuccessfully managed. And because of all, there is a lot of psychosocial behavioral implications on the children. So definitely it's a challenge for every parent, for every dentist who have seen children, especially between 3 to 5 year old, and the age of 3 to 5 years, because of the increased stranger anxiety in them, because they have never been to school, they have never been having a social interaction with anyone. So the kind of children who we have seen the last 2 years, I've been really, we have been in a really bad situation, and that's because of the impact they had on parents. So definitely, how can we modify this in our practice? If it's a very small child, you know that the child trusts the parent much more than anyone. So if it's a very small child, probably below 5 years, I always say that let the child be seated on the parent's lap. Or when you're going to do a procedure also, never make a child to sit alone on a dental chair, because he feels he is, being observed a lot. Rather, if he is on a parent's lap, it gives him a lot of comfort, because the one he trusts, he can even hold the parent's hands, so that, even if you're trying to talk to him, he knows that his parent is talking for you and things are all going to be under control. So definitely placing a child on the parent's lap would definitely make a big difference. Parents also know your likes and dislikes. Child is fearful. You can always talk a story, one of his favorite cartoons. You can talk about one of his favorite, hobbies, or one of his favorite picnics, and totally distract. So parents especially do have a role when the children are very young. So they know their likes and dislikes and all that. And accordingly, it is easy for us to manage our treatment when the parent is around. But however, there are also situations when the parental presence and the parental absence have their advantages. When it is a parent is present, it is going to be very supportive. It's going to, the communication between the parent is also happening over there in between, and the child is going to be very accommodative with you. And however, this doesn't work in certain cases. Sometimes, as I told you, if it's an authoritarian parent, the parents are going to interfere with whatever conversations you have with the child. He will try to interrupt you, and he will also talk on behalf of the child. In such conditions, and also, as I told you, parental conditioning. One of the parents is really scared of dental treatment, and he makes all sorts of weird noises when you're trying to give a local anesthesia. Oh, 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 and all he makes, sounds like these. Definitely, it's going to have a negative impact. So, and having a parent who is going to disrupt your kind of communication between the child and the dentist is definitely going to be harmful for your practice in the future. Assessment of the parent, as I told you, is very important. Also, I would also suggest, suppose you treated a child today and probably you had a bad time because the child's dental needs were, you tried to do a pulpectomy, but then eventually it could not be worked out well, In such situations, probably you had to raise your voice a little bit. And finally, the child and the parent all went, quite disturbed. They were upset. Even the mother ended up in tears and all that. I would always suggest, in such situations, have a check on the child's well-being post-treatment. Maybe it is just a phone call. Probably you can call him probably the next day morning and just check out on how exactly he's, going through the day. This will definitely give a positive impact to such, in such cases. Probably if the mother was planning to badmouth you, in front of the whole community or relatives or something, a phone call from you might make a huge difference. So I would always say that in situations where things go unexpected from what you have thought of, always a phone call would make a big difference. have a phone call. And this will definitely increase the rapport between you and the parent, and eventually the child is also going to get affected. Suppose in certain situations where you will not be able to do or treat a condition with probably ECC. Suppose you wanted to do a filling for the child and it did not work out because you had to do a little bit of excavation or something like that with a burr and it did not work out. Always an option of silver diamine fluoride should also be considered in such situations, because child is very fearful. However, the parent doesn't want general anesthesia and they don't want any other invasive kind of procedures. Always an option of silver diamine fluoride, which is nowadays much in use, should also be discussed with parents. It should also be incorporated, our kind of counseling, right from the beginning, from prenatal and postnatal stages. The early prenatal and even the early postnatal period, of what are the do's and don'ts of oral hygiene practices, both for the mother and the child. Because it is said that if things go well right from the beginning, children who are born to these parents are going to have lesser oral health complications. They said that temperamental differences also at an early stage in the prenatal period can have their influences in their child. So when you want to counsel parents, rather than focusing alone on oral health needs, you should also give emphasis on the kind of relation you have between your partner, between both the parents, because that definitely also has a positive impact. Also, when you are pregnant, when the parent is pregnant, you have to advise them. Keep away from all disturbing conversations and thoughts. Eat healthy, keep diet balance, engage in activities that increase the bond between the child and yourself. And always, if you have any doubt, get back to the experts and try to learn what exactly they have taught you. Once a child is born, learn again from the experts. How can you best do infant oral care and weaning practices? And always visit a dentist at least when the child's first tooth erupts. At least if you give this much amount of knowledge, the parent is going to accept you. You are going to be their family dentist forever. They are going to come for their child's needs, their parents' needs, and whatsoever. So you are going to become the dentist for their life. Also, as I told you, the maternal negativity and positivity have a lot of impact on preschoolers. Maternal negativity has been shown to have poor social functioning, and positivity has better social outcome in day-to-day life. So definitely this should be a part of prenatal and postnatal counseling, and that definitely can bring about a positive impact. Also, you should tell them of healthy eating habits. You should tell them what is practiced at home, so is practiced, in their life ahead. If parents have the ability or have the habit of eating good food, good nutritious balanced diet, that is very well incorporated in the child's dietary patterns, and that has a positive influence in bringing out good oral health in the child. Another aspect that I would like to include in the parental section is the role of grandparents. What we normally miss out are the grandparents or the other caregivers who are there at home. So you have noticed that once grandparent comes along with the parent and the child to the clinic, the grandparent is very touchy about the child's crying and all that. And if the child cries, probably he just picks up the child. No, please stop the treatment. No, he is. So what you have understood from this is there's a lot of negative outcomes because of the lack of awareness of the grandparents. So in your counseling, you should also understand what is the level of knowledge of the caregivers who are there at home. They should also understand it's not just, you should not just focus your practice on parents alone. You should also expand it to the grandparents. So try and do things at the right time and incorporate grandparents also in any kind of counseling strategy that you would like to put. The next and the last phase of today's presentation is the interaction between the dentist, dental team, and the child and the parent and caregiver. a pediatric clinic can be considered as a healing environment. And this is nothing but a holistic environment which distracts the patient from anxiety and facilitates effective patient rehabilitation. Said that if it's a good clinic, if it's a clinic which gives a lot of positive energy, it's going to play a vital role in the physiological and psychological health of the child. And this place is going to be a place memory in the child's life. Little bit of architectural modifications here and there can also bring about a sense of relaxation and comfort to children, especially. It supports communication development and brings about a lot of positive emotional reactions, and they will also accept you and your clinic better than anyone else. What are the common mistakes that are seen? Especially if you are focused or focusing on a practice where children are meant to come, definitely these are the most commonest mistakes. A boring waiting area where there are no attractions for the child around. This is another place where the glasses are all transparent and you can actually see, the other person being treated. If he has a very bad time, probably all that is visualized through these transparent glasses that are there around, and there's a lot of communication and all that happening all over, and the child is going to get really tensed with an atmosphere around. So this is also another situation where chairs are all placed adjacent to each other and each child can see what's happening next. If one is crying there, definitely that's going to influence here. So these are some of the most commonest mistakes that are seen if at all you're aiming for a child-centered practice, or you're aiming that every child who comes to you should remain with you, then these are the common mistakes. And how can we best such kind of setups? So this is another situation. Now we know that there are all high-tech clinics. And if it is something like this, do you think a child is going to accept you better? I would definitely say no. Probably this could be a good adult room, but then however, for a child, it should be something very colorful. The reception, the play area, the chairs, all this make a big difference in the kind of approach a child has to you during treatment. The waiting and the play area. So now if you have to talk about the waiting area and the play area, I would first primarily say, try to make the waiting time of the child in a waiting area as low as possible, because children tend to get bored easily and their anxiety also tends to build up more and more the time you make them wait in a waiting area. The quality of the room definitely has a good impact. If you have staff appointed in your reception, try going to talking to children and make them feel at home. That is also going to give a good positive response. Children would prefer walls with cartoons, with pictures all over, and they love to spend their time in a clinic like that. However, there are some children who do not prefer a lot of toys, but they would prefer somewhere to sit idle, read some books, or draw a picture or something. Make a space allotted in your clinic where you have allotted spaces for either sitting and reading or drawing a picture with crayons or something kept there. That is going to make a difference. The waiting area, if it also has some facts in the form of the teeth and the oral health practices in the form of comics or in the form of cartoon characters, that is also going to be get very well accepted by children. If you have a board, a bulletin board with a lot of picture displays of all those pictures that have been handled by your previous patients, that is also going to be, a positive impact, give a positive impact to children, because they also would want to have their name, their picture displayed in the future, and definitely the child will come back to you with a picture in the next visit. Children, though, would prefer to sit idle in front of TV. So if you have a TV also in the reception area with some cartoons or something which is very funny or a comic, that is also going to gain the positive attitude in your practice. And of course, if there is an ever smiling and a welcoming and a friendly nurse, especially appointed for child practice, I'm sure to say that parents would accept this clinic better than anybody else. Even beyond the dentist, if the nurse is very comforting and she is there with you, definitely parents are going to accept you better. Now, there's also a conflict in literature. White coat required, not required. They say that some people, because they have been idealized, they have this idea of the white coat people always there to protect you. There are a group of respondents who say that white coat people are the best and they are there only to treat you. While the white coat also has its negative effects, because we have always seen a nurse who is in white coat who is there to prick you. So they try to relate every white coat to that particular nurse who has always pricked you. So it's always a conflict. Some say white coat is better, while some say white coat is bad. But then, however, I would suggest that if if you have a child practice or you have appointed, you have kept time for child practice alone for this particular period, definitely if you wear, a suit, a scrub suit, which has a multiple number of cartoon pictures, etc., children are going to accept you even better. Probably this is not where if you are trying to treat a child of 16 years and you come like this dressed, probably he's not going to accept you because he feels that you have accepted him as a child. So what I'm trying to emphasize here again and again, understanding the mental process according to the child's age is very essential when you are doing a child-centered practice, or you want to treat children with in between your adults in practice. Communication, very important, very essential. A dentist should have a good communication skill with the parent as well as the child. And it is primarily said, you come down to the level of a child. If the child is too small, you kneel down in front of the child and talk to him face to face. The child is going to feel that he is, kind of your age, and that's how he tries to communicate with you better. Bow down in front of him, he's going to accept you better. If it's a normal child, they say that verbal communication should be much more than non-verbal. Non-verbal is nothing but probably a handshake, a pat on the back, or etc. So communication plays an essential role in normal children. However, in children with special healthcare needs, they say that body language is much more important than the kind of language you use for communication. The body language, if you are very happy and you're very expressive, that's going to make a child with such special healthcare needs accept you much more better than the one who talks in very good language. The tone of voice is also important when you're talking to a child with special healthcare needs. If you have a very humble and very, that care tone is there in you, the child is going to accept you even more better. There is also something called as pediatric dentistries, which is nothing but a high-pitched, repetitive word adults speak to infants. It's called baby talk. If you know, this is the kind of the way that a parent is titling their child at home, like Momo, Choo Choo, or, it can be anything. If you understand this from your case history, you talk to the parent and find out how do you introduce or how do you call or title the child at home. If you get to know that, title the child the same way, the child is going to get shocked. The child will be so happy probably, and he is going to accept you even more better than calling out his name, reciting his full name. You call him in different words, or probably, talking all these broken words in between, can definitely create a lot of impact on child acceptance. Using euphemisms also play a vital role, especially in children below 6 to 7 years, to 7 years of age. You can definitely replace certain terms like air syringe, water syringe, like wind blower, water pistol. If you're using a rubber dam, you can say a raincoat. If you're using a stainless steel crown, you're going to place a helmet on the tooth. Such kind of small terms that used. Definitely, again, child acceptance is going to be very high. So the use of euphemisms definitely has a positive impact. The next is nothing but desensitization, modeling, and distraction. Telling the child, showing the child, and finally doing the procedure. Or asking the child what is the problem, and then telling the child what exactly is the solution. And again asking the child what is his problem, time to time, or telling the child that you're going to do this and playing it on an object and then finally doing it in the patient's mouth. So it's called tell, show, do, or ask, tell, ask, or tell, play, do. If you practice all this, again, children are going to accept it better. Modeling is either with the parent. You can make the parent have this, or the younger sibling watching the elder sibling being treated, or you can make a little more elder sibling, a little more elder child go and watch another child being treated in another chair. These are all different kinds of modeling. So the child tries to model that kind of behavior and then tries to behave well. So this is the role of modeling. And then a very simple thing is distraction through some kind of audiovisual media. Probably it's a TV which is attached on top, which is playing cartoons. You can always ask a child, what is his favorite cartoon? And play it. If you have a cable connection, play it. The child is also going to get totally distracted and focus himself on that. One more thing I would also like to add in this particular aspect is, what is the maximum allowable time that you as a dentist should spend with a child on a dental chair? You say that all textbooks, when all articles say when you're treating, you keep the time much minimal. What is much minimal? I would say the maximum time for a normal child should be like between 30 to 45 minutes. That's like the maximum time you should stretch your appointment with the child on a dental chair. And if it's a special needs, I would say definitely not more than 30 minutes. That's like the stretch of time that you can spend. The more time you spend with the child on a dental chair, child is going to get bored, fed up of treatment, and probably is not going to come again. Rather, if you just finish it fast and it's painless, child is going to come back again. So try and keep the child gets tired and annoyed. The child's mouth is kept open for quite a lot of time. Even the parent is going to get annoyed with you. The parent will think, how is the child's bones over here, the TMT and all that will hurt. So he might come and tell you, see, doctor, he's keeping his mouth open for a long time. Why do you come to such embarrassing situations? So I would say, cut short your time. Cut short your time to not more than 30 to 45 minutes in a normal child. And if it's a special needs patient, you have to limit it to a maximum of 30 minutes. If the child is behaving good, never bribe a child that you're going to give this. Rather, it should be a surprise gift. It can be just a certificate for his good behavior. It can be sometimes just a toothbrush that you give. So it could be some kind of positive reinforcer, some kind of material reinforcer, some kind of social reinforcer. Any of these, if you give to a child, definitely the child is going to accept. I would say never scream at a child. Child has some kind of innate fear. So it's not good to shout at a child. You have not been given the right to shout at a child. Rather, talk to him peacefully. And if things do not work out on a dental chair, definitely there are other options how you can best treat him and gain his acceptance. Move on to that stage. You are not here to negatively reinforce the child by shouting at the child. But however, if the other ways are practiced, the child is definitely going to come back to you. As I told you, his favorite cartoon. There are so many cartoons available. Choose his favorite cartoon and put the child. Child is going to be really happy. If you do not have a cable connection, have at least some set of, in your USB drive or something like that, and connect it to the screen on top. And he is going to get totally distracted and really too happy about you playing it for him. He knows that now you are prime importance. He might come here that day and just tell you, okay, I want this particular cartoon. Just put that. Just put it. I'm telling you, he is going to sit for your treatment well and good. Now, will color make a difference? I told you. Again, there are so many studies. Yellow was found to be the most acceptable color, and blue was found to have a good calming effect. However, green was least preferred for sadness, and red was preferred for utter sadness, and black nobody liked. So this is the kind of mind process that is happening usually in children. So blue is meant for security, calmness, and comfort. Yellow gives happiness, cheerfulness, and that's why all these emoticons are all in yellow in color. The green is meant for quietness. Red is expressive for aggression or excitation, and black definitely for depression. And there are a lot of authors who have commented that colors do have an impact on a child's life. Then do you think orders have? Orders also do have. Suppose the child has, this kind of fear for certain kind of orders. It is called as Prost phenomenon. It's like this particular smell is, when he goes to a hospital, he knows this is the kind of smell they are around, and that's the same that here. And that is a place, that hospital, which gave him a lot of fear. He's going to relate all that here. He feels this is the same kind of environment like that hospital because the smell is the same. And what are these kinds of aroma that can definitely cause a negative behavior? The usual unacceptable things are the smell of spirit, the smell of eugenol, the smell of acrylic monomer, certain waxes, and sometimes highly scented products are there. And especially you should keep them away if you know that this child has some respiratory illness. Usually acceptable taste smell is the smell of mint or strawberry, or the smell of some citrus fruits like orange or something. They say that children accept it much more better. They say that these kind of things, they alter this, the state of humans. If it's a very pleasant taste as order, the child, when they walk into the clinic itself, they feel, wow, it's such a beautiful place. You smell good air here. And they try to accept the clinic much more better than anywhere else. Sensory adapted dental environment is something which is much more suitable for people with special healthcare needs. It is also suitable for people who are normal as well, but however more accepted by children with special needs. Dim lighting, moving projections such as fish or bubbles. If you have a projection on a wall which is facing the dental chair and it has a lot of bubbles and fishes and all that over there, the child is totally going to get distracted and go on to some world. A soothing background also can give a good positive, impact. And if it is a child with autism or something, they say that if you wrap the child with a kind of a heavy blanket. There are these kind of blankets where they get a very cozy kind of feeling. If something like that can be provided, child is going to accept it. Picture exchange is another method if children cannot communicate well. If children have difficulty in communication, some sensory defect where they cannot communicate or express their emotions. If you have these cards kept there on the table and you tell the child, you can pick and choose. If you want me to stop, please pick up the one which says break. If you want something, you want some help, you want water, you want something, you can pick and choose whatever it is. So this is nothing but the picture exchange communication system. If this is also introduced in children who cannot express themselves because of their sensory deficit or because they are too small, definitely they will feel much more secure with you because all these cards are there around. They can just pick and choose what is their situation. Animal assisted therapy is also done. Usually it's practiced in the US and in the Western hemisphere, where they have introduced animals who are very trained and certified. And they say that in the case history recording, if they know that the child is very fond of pets, especially if it's a dog, they have these trained dogs, certified dogs who do not harm. They are brought in, they are set in for that day. They get them inside the clinic and they are allowed to spend some time with the dog. And this gives them a lot of positive energy and they feel that they are at home. So this is called animal assisted therapy, which is also introduced, in the Western Hemisphere, which may also come in India much more. And as I told you, if nothing works out, all these practices, whatever you have tried, communication, all kinds of desensitization, modeling, contingency management, all these techniques have been tried. But, the child still lacks cooperation. Probably to a certain extent, this is another process that, procedure that can be introduced, nitrous oxide sedation. Which is a mixture of nothing but nitrous oxide and oxygen. You have the cylinders, you have almost all colleges are introducing the same, as well as clinics have also been started using carbon dioxide. If you have good sufficient training on the use of it, I would always say go for it. So if this is there, the indications, you should always know that they have their indications and contraindications. Only if you are well aware of what are the indications of these. So definitely a fearful and an anxious child, it is suggested. A special healthcare needs, certain special healthcare needs, like probably an early autistic, a mild autistic patient, even if you give this, definitely that is going to be, it cannot be given in all severely debilitated conditions, but however, in certain special healthcare needs, it can be introduced. If child has has gag reflex on anything you put in the mouth because he's consciously thinking that something is going to his mouth, definitely this could be an option. And patients for whom you feel that you need a lot of time to work. A lot of time means, as I told you, within the time frame of the child on the chair. So if you need a lot of profound anesthesia or it's a slightly lengthy procedure, definitely I feel nitrous oxide is the best solution. Whatever method you use, whether it's a nitrous oxide or whatever it is, informed consent, assigned informed consent should be obtained from the parent. And if the child is below 18 years and he knows to comprehend what is the kind of treatment that is going to be done, he's below 18 but probably above 6 or something, an assent, an informed assent is also to be recorded in the case sheet that you're having, because there are a lot of medical cases that are coming nowadays of maltreatment of children in practice. So I always, whatever new method that you are planning to introduce, make sure you have documented after informing the patient verbally. You are, explained it also by written and verbally. Get a signed consent from the parent or the caregiver, and also the child can understand, an assent is also. However, when in doubt, it is always best to consent. Don't attempt a child and spoil his kind of nature. If you have a doubt that you're doubtful that you cannot manage this child yourself, I would suggest it is always best to consult with a specialist or with a senior dentist or with whoever you feel comfortable and you have trust that that person can treat your patient. I would request better is to consult. It's always good to conclude this presentation with a quote from Raymond. Getting into the good graces of children is almost half the work to be accomplished. Thank you so much for your kind attention. I especially acknowledge all those people who have contributed their best in providing me with information for this presentation. I also give my special thanks in this platform to Dr. Elizabeth, who kept giving me insights of what exactly she felt is the topic on and what are those best ways that I can improve on the presentation by her inputs. It was very valuable. I thank you from the bottom of my heart. Thank you, ma'am. And I thank all those people who have been attending this lecture. Thank you once again.
Thank you, sir. Thank you, sir, for that wonderful section. Now we move on to some questions. So first question is, if child is feeling anxious by more talking, then how to manage him in dental treatment?
The child is, sorry, can you just
feeling the child, if child is feeling anxious by more talking, that means for communication level, we are talking more than enough, the child is feeling anxious, then how to manage?
Okay, now you know from the assessment of Frankel what exactly the child is. So if you know that this is going to be a negative or a definitely negative kind of behavior, probably by the kind of questions that he is asking, I would say never to initiate treatment on that first visit. Always it is better to start with the most least provoking treatment in the initial days of your appointment. Start with the least anxiety provoking procedure. Now this is one part of it. Now, if you know that the child is anxious because of all his questions, please take 10 minutes of your time and try to understand what exactly is his fear about and try to actually educate him or try to help him out probably with pictures and photographs or whatever you have. Try and explain what exactly you're going to do. You know, such kind of fears can be combated if you spend enough time with him in private. can also make the parents sit there and closely observe, and you can always advise the parent to remain silent and just do the talking. The child is going to accept you much more better. So this is my insight to it. So start with the least, fear provoking procedure, and try to spend more time with him privately, not in the dental chair. Probably get into your room. Get into a room where he feels that he's much away from the dental setup, and just talk to him. I think things can be made better, and try to start your treatment from the next visit.
One more question is there, sir. How to communicate with reserved child and make him to accept dental treatment?
Okay, this is exactly somewhat the same of what I just explained. It's a reserved child, and this reserved child is probably because of the kind of behavior the parents are. Now, an authoritarian parent would definitely have a reserved child, because they are always the boss and they feel that whatever they feel, this is what the child requires. But that's not the case. So in such kind of situations, it's always essential to also communicate with the parent, because it is the parent who has probably made him as a reserved child to shy away from things. So first, in such situations, you have to educate the parent and probably tell him that there are probably in the child's absence, that there are situations why children shy out. You should make it more expressive. You should allow him try. The only way to drive out fear is by good communication between you and your child. So you being an authoritarian parent and trying to inflict all those kind of rules in the family, probably that could be a reason why he is like this. Now, this is one aspect of it. When you talk to a child who is much more reserved, you know that the child is fearful of so many things. Try to draw out fear. Tell him that fear is normal. This is a part of, every child. Fear is normal. It can be easily, driven away if definitely you give more attention to the kind of fear that he has. So he can drive away fear only by he himself thinking about it. That's my insight.
Thank you, sir. Thank you once again. Now
Thank
I
you,
request Dr. Sublashni to say a word of thanks.
A very warm good morning to everybody present here. The duty of thanking everybody to have been here falls upon me. Let me begin by thanking God Almighty for this wonderful opportunity that we had to organize a program like this, and for it to have included so many participants today. Special thanks are due to the management and staff of Pushpagiri College of Group of Institutions, and a special mention of Father Eddie Vadakundala, who's the Director Institutions, who's always encouraged all our efforts to bring out programs like this. Let me also thank the principal, Dr. George Varghese sir, for joining us today, and for all the support extended for coming up with this program. Thanks are also due to the head of the Department of Pediatric and Preventive Dentistry, Elizabeth Joseph ma'am, who came up with the concept of this program and who took all efforts to make sure that it happened in this manner today. And next, let me thank the speaker of the day, Dr. Arun. It's always a pleasure to listen to Dr. Arun, because it's like it's an experience by itself. We can, though when we're listening to it, it's just like listening to a lecture. We can always see the efforts and that goes in the preparation and everything. Thank you so much, Arun. As usual, it was wonderful, and I think we are seeing those messages in the chat boxes too. Thank you. Thanks are due to all the participants who have registered for the program and who have joined in and listened to us today. The heads of the departments of pediatric and preventive dentistry, heads of the departments of various other specialties who have joined in, faculties from different colleges all over India, practitioners from in and around Tiruvalla and other states, the postgraduate students who have joined us today. Thank you all. And I'll be failing in my duty if I do not recognize the efforts of the team, Pediatric and Preventive Dentistry at Pushpagiri College of Dental Sciences, for all the efforts in making sure that things went smoothly today. Thank you. I hope everybody had an enjoyable experience. We'll be sharing the feedback form and the certificate link with all the registered participants. Kindly fill in the feedback to receive your certificates, which shall happen within the next 2 or 3 days. Thank you so much.
Thank you so much.
Thank you all.